Thanks for that introduction for this first of the CAW webinar series. Topic is price transparency. And I'll just start by giving a little bit of information about myself. For those of you who don't know who I am the partner in charge of revenue cycle here at Eide Bailly. I've been with the firm for about 3 years, but I have worked with, I was here before, probably about 15 years ago, and I worked in the reimbursement group then. And that's kind of what my background is reimbursement, revenue integrity, compliance, healthcare finance. And I've been doing this for quite a long time. And I would like to introduce Rochelle Damon, who will also say a little bit about herself, but she's also a comeback kid too, to Eide Bailly. And both of us are out of our Minneapolis office, and happy to have her back at the firm. So Rochelle, just say a few things about yourself.
Yep, no problem. I'm a healthcare consulting manager, like Amy said, out of the Minneapolis office. I just recently came back to Eide Bailly. I have experience in a wide range of areas across the healthcare revenue cycle, including charge master, charge capture, a lot of work in the technical aspects with EMR, implementation, build, as well as all the pricing studies and price transparency, which is why I'm on the call with you guys today.
Thank you. So we're just going to go through start with the history of price transparency, and you'll find out that this really isn't, even though it seems really new, it goes back quite a long time. It's been in their works for at least 10 years. And then we're going to go through and talk about the final rule and the requirements around that. And then just talk about some suggested approaches and tactics and things that you might want to consider if you haven't already. I know the deadline is coming up soon for compliance, and just some other related considerations that kind of relate to pricing, just to kind of put it in, I'll make it more well-rounded, I guess. So as I said, this isn't anything new. This goes back to the Affordable Care Act, or the Public Health Services Act, which was enacted in March of 2010. And if you look at the language from the ACA, this sounds just very familiar. And it's kind of like where we're at today with what's required for price transparency, because we are required right now to do some things for that. And basically what it says is that every hospital that operates within the United States each year shall establish an update and make public, in accordance with guidelines developed by the Secretary, a list of the hospital's standard charges for items and services provided by the hospital. Those words really kind of resonate with me, and it sounds very much like what we keep hearing and what we've been doing to date. But for those of you who have a little bit of information on the final rule, we've got a little bit more definition around some of those terms that are in that sentence, if you will. So 5 years later, in 2015's inpatient prospective payment final rule, they said, we're not sure we're seeing what we want to see here. So they had a couple lines in that final rule, and basically one of the things that you could do to comply with what they were looking for was, if your hospital association actually published, the top 15 or 20 or even 50 Medicare DRGs, the charges for those by facility, you could just provide a link on your website to that to give patients, here, if you want to find out more about something about how much a charge would be for this kind of a service, you can go to the hospital website. And if you didn't have that capability, I think the government was looking for something a little bit more specific maybe on your website, but that was one way that you could get to be compliant for that. So then in 2019, again, through the inpatient prospective payment final rule, that's where we're at today. That's the current landscape prior to the new rule. So you are currently posting your standard charges on your website. This was effective January 1st of 2019. It had to be in the machine readable file and updated at least annually. And then prospective paid hospitals had to provide a little bit more information on MSDRGs. And after that came about and we thought, oh, here's all this price transparency. People were, and this is something out of a New York Times article. Okay, the hospitals posted their prices, but it still takes a brain surgeon to decipher them. So keep that in mind as we go through this. So then in February of 2019, the ONC proposed rule was out there, and I don't generally, follow that guide, that agency necessarily. However, it was brought to our attention that they were looking for some comments on pricing and penalties potentially if you don't provide pricing information. And then they even talk about, should we make it public what these negotiated rates are? And I'm thinking, does CMS have the legal authority to do that? And I know that's something that's currently being challenged in litigation. I found it odd that the rule that's talking about interoperability of electronic health records had stuff about pricing. But as those of us who've worked in this world for a while know that sometimes CMS might be having something, that they've been talking about, and oh, there's this rule that's coming out. Let's kind of get it in there and get some comments. So that's the only thing I can think of as it relates to that rule and why we saw some of that information in there as it related to pricing. But based on what I'm just talking about right now, you're going to see those things kind of mattered. In June of 2014, or June 24th of 2019, the president issued one of his executive orders, and he directed HHS to issue regulations requiring hospitals to post charge information. And what that went on to state was, we also want you to tell us what the charges are that you need to post. We want negotiated rates and shoppable items and services. And then in 2020, the outpatient proposed and final rule, which came out in November, the final rule was November 15th of 2019. There were lots of comments sought based on all of those things that were in that executive order, many pages in the proposed rule, and talk about the charges, negotiated rates, and shoppable items and services. And that is all now effective for being on your website on January 1st of 2021. So less than 60 days away. One other thing to note, and this does not apply to critical access hospitals, but in case you've heard of this, what this means is that in the 2021 IPPS final rule, they finalized requirements for PPS hospitals to report Medicare Advantage plan rates. They're actually requiring or going to be creating a new worksheet to report this information on their cost reports. This was something that was kind of alluded to in the proposed rule, and maybe even in the final rule. CMS has been looking at, does it really matter to use the charge master anymore to set rates for the prospective paid hospitals? And so the goal here is that they're going to use that data to set rates going forward sometime in and around 2024. So just something else to be aware of. Well, I call it shock and awe because when we saw what was in the proposed rule on this, from what where we're at today with, we're just posting our charge master. And CMS's rationale for this is that, healthcare costs continue to rise. You know, it's 20% of the economy by 2026. And we have a lot of people that are on high deductible health plans, and they are the ones seeking this pricing information, as well as those people that don't have insurance. And the other thing that they point to is that, you know, already more than half of our states have state transparency requirements, you know, so why shouldn't we have more, make it more standardized? And in the proposed rule, you know, they say that they want, you know, the patients obviously want to make more informed decisions. They feel that this is going to increase market competition and hopefully drive down costs and thus make healthcare more affordable. Well, a lot was published in the proposed rule. And when we get into the final rule, you're going to see that a lot of what was in the proposed rule ended up becoming finalized. But what happened is we now have a hospital price transparency section of 45 of the Code of Federal Regulations. It's part 180, and that now all of the things that we'll be talking about here in the next few minutes are actually part of the federal code. So they're housing these regulations right within the Public Health Services Act, and I give the citation there. And again, going back to help high deductible health plan enrollees and others seek that information to help them make informed decisions. So now we have terms that are defined in the code. The type of report is now codified. The elements to report are laid out in the code. So it's as if, you know, they don't want to leave anything unaddressed. And then, you know, they sought comments on, well, how should the government monitor this stuff? And should there be some sort of notification of non-compliance? And then what about penalties? And should there be appeals process around those facilities that do not comply with this rule? So as I mentioned this, you know, one of the things when they were talking about should there be any sort of reporting, should it be done on a public website rather than on everybody's, you know, on a standardized format rather than having it as part of a hospital's website. Those were all things that they were looking for comments on. And some of what drove this is they saw what hospitals have currently reported on websites, and they noticed, you know, it's not in a consistent manner. Some facilities had, you know, they just put a description in their gross charge. Others did a lot more, you know, where they're putting the charge code and the description and all the other billing type information with CPT codes. I mean, back when the rule came out for the 2019 implementation, there was a lot of, it happened so fast, and there was some concern about using CPT codes because of the proprietary nature of that. And that has gone out, you know, they're basically saying, no, you can use your CPT codes and publish those. And then they talked a little bit more about this, what's standardized, you know, around that. So the final rule where we landed, all of these things on this slide are things that have been defined in the final rule. We now know what a hospital is. I think we thought we knew what hospitals were, but now we have a federal code definition of what a hospital is and what a hospital is not. Different reporting requirements are codified. What is a standard charge? That's the area that has been, you know, I would say the shock and awe, that's an area that applies to. We have definitions around what are items and services, the machine readable file, shoppable items and services, public disclosure of non-compliance with the rule, actions that address the non-compliance, and then what sorts of appeals are out there if these, you know, you're assessed civil monetary penalties for non-compliance. So with that, I'm going to turn it over to Rochelle to go through the actual details around these requirements.
Thanks, Amy. And as Amy said on the previous slide, they did define what a hospital was in the rule. And straight out of it, it's the definition that they published was a hospital means an institution which is licensed as a hospital and is meeting the standards established for such licensing. So that's fairly broad. So that is what they define as a hospital in the final rule. It pretty much encompasses all types of facilities. The only exemption would be your federally owned and operated hospitals that do not treat the public. So critical access hospitals are part of this. All states plus DC, Puerto Rico, Virgin Islands, Guam, American Samoa, and the Northern Mariana Islands are all part of this as well. So, you know, it pretty much includes everyone. And also, if you have different locations that are part of your hospital license, such as an off-campus department of the hospital, that would also be included as part of this. Okay, next slide. Also, one of the things that they defined in the final rule was the standard charges. With this, it's not just our charge that we have for our item and services that we're supplying to the patient, but with this, they also went to define more types of charges, including our negotiated payer-specific charges and rates. So basically, any payer that you have a contract with and they pay separately for an item or service needs to be listed in this. So it's not as simple as here's a column for that information. You could have one payer plan or one payer with multiple plans and rates negotiated under that. So you may have Blue Cross Blue Shield, but you could have 3, 4, 5 different contracts under Blue Cross Blue Shield. And all of that needs to be spelled out in this as far as what a standard charge is for the negotiated specific charges. And then also you have to list your cash discounted price. So if you offer a different price for someone paying out of pocket, that has to be listed for that service. And if you don't have that, you would just put your gross charge in that column, but you must signify a charge for that. And then along that, we need to list the de-identified minimum negotiated charge. So that would be all your payer contracts, you know, that I go like this because I see it listed as columns across your spreadsheet. It would be the lowest of all of those would be your de-identified minimum negotiated charge. And then your de-identified maximum negotiated charge would obviously be the highest paying of all of those. And with this, you know, they say all this should be in your system, but they feel that the burden, you know, of getting all this information public and out there outweighs the public's need to access the information. So there's a lot of work ahead to comply with this. So next slide. So along with the definitions, another one are items and services. So this would be basically simply put all the line items in your charge master that have a charge associated with them. So if there's 0 charge line items or line items that you don't receive a reimbursement for, those can be excluded from this. Also with this, they said you have to provide any services for employed physicians and non-physician practitioners. And this was not clearly defined in the rule as to what is an employed physician. So that one's a little bit of a gray area, but if you do provide the service and the physician is employed, that is another thing that you have to pull. And with that, physician services are sometimes in another system. They may be on another EMR. So you would have to pull that information as well and gather it and compile it and also post it on the website. And another definition is a service package. So there could be common surgical procedures where there's like little variation in the service that we may bundle something. An example of that would be like your cataract procedures where there's very little variation. No matter what's done, we get charged a standard price. So that could be considered a service package. You bundle, you know, the lens, you bundle any kind of pharmaceutical items, surgical time, all of that would just be a one package price. So that's something to consider with this too when you're listing out all of your charges. How do we list those types of items and differentiate them from the rest? Next. So this is the complicated part. You know, they state that the hospital's billing and accounting system should maintain all of this information. which I mean is true, but it's not always easy to get at. It could be in multiple systems throughout your organization. We have our EMR that houses some of the information. We have accounting systems, possibly contract management, our claims. All of this needs to be aggregated in order to provide this information and to be able to post it. So it's not as simple as just downloading a spreadsheet and uploading it to the internet. So the rates are defined by the payer and the product. So depending on what type of contracts you have, you could have a fee schedule payment for a service, and then another payer would be APC. They could have a surgical case rate associated with it. So it's not always apples to apples across all the payers either. So how do we do this and make it readable and understandable for the public? We do have to include all of our negotiated rates, including all commercial payers, Medicare Advantage, Medicaid Advantage, or excuse me, managed Medicaid. But traditional Medicare and Medicaid rates can be excluded because they are publicly displayed already. You can go out on the internet and find them on the websites. And with this, critical access hospitals don't always have the resources to gather all this information. I foresee almost needing some kind of a BI tool, a business intelligence tool to compile this and get all the claims data to really get a clear picture with everything. So it's very resource intensive. Some additional requirements, we must keep these files updated annually at a minimum. I would recommend building a file that's easily updatable. So it's not like a one and done, you post this one time and that's it, you never have to worry about again. I would recommend, something that's easy to change formulas and whatnot, so you can update percentages if your payer contracts change, kind of build it as a living, breathing document. I would recommend updating it anytime you have a major change within your system, like you add a new department, maybe you add new services, you discontinue some services, close an area of your facility or close a outpatient clinic, or if you update your prices, I would recommend updating the file. And then as far as machine readable, they didn't define an actual format that you have to use, but it cannot be a PDF file. And when we go out and look at clients or look at hospital websites and look for the files for the 2019 compliance, I'm often seeing PDF files, and that would not comply with the machine readable. So I recommend doing like a CSV or an Excel file for this. And they did come with a standard naming convention. So it'd be your tax ID, hospital name, standard charges, and then whatever file extension. So they did at least standardize that. It also needs to be easy to find on the website. Some of them are really, really difficult to get at. They're in little fine print at the bottom of a web page, like 3 clicks in. So you want to make sure that it's prominently displayed, it's easy to get at, and you don't require an additional login through a portal or anything for people to get to it. It also needs to include all of your standard accounting, billing information for the item or service, like your HCPCS codes, your CPT codes, your revenue codes. And then the comment at the bottom, where they say, we do not believe that making a public comprehensive machine readable file with all standard charges for all items and services would create patient confusion. Well, I don't know about you, but sometimes I look in a charge master and wonder what something is that I'm looking at, because there's a lot of abbreviations used. You only have, you may only have 25 characters to describe an item or a service. Just think how confusing that'll be for someone off the street trying to find what they need in this file. Okay, next slide. So shoppable items and services. So this is something else that they defined in the rule. These would be services that are generally scheduled in advance, something that, if someone is paying out of pocket, they're going to want to shop around for the best deal. So these would be things like your colonoscopy, routine labs, therapy services. CMS is requiring they have like a list of 70 items and services that are required to be published. If your organization doesn't have one or more of the 70 items or services, you have to still list it, but put NA or does not apply or something to clearly state that it's not available at your facility. And then with that, we have to list an additional 230 services or more, depending on how many of the 70 that you don't apply. At the end of the day, we have to be able to meet the requirement of at least 300 shoppable services for patients. And things that they have listed in the 70 for CMS would be your lipid panels, psychotherapy, office visits, physical therapy, removal of tonsils, those types of things that, you know, people generally do shop around for if they have the ability to go to another facility where they can get a better rate. This is one of the things that I think is going to be the most complex part of it, because depending on how you have your charge master set up, it sounds simple. You know, someone's coming in for a colonoscopy, we need to tell them how much we charge for this. Well, some facilities just have one charge that says colonoscopy, and your payer just pays, you know, one rate for that. If you don't do that, and you line item bill all your ancillary services, like any pharmacy items related to that, OR time, supplies, if you have a separate charge for that and your payers pay that, that has to be listed with the primary service. So this is where you would most likely need claims data to see what kind of items and services are commonly reported with these, and these also have to be reported. So we'll get more into that as we get into some technical stuff later on. Okay, next slide. So with the shoppable service posting, I feel one of the more complicated, other than listing out all the rates from the payers, is the plain language description. As we know in our charge masters, most often we're not using a description that someone can easily pick something out. We tend to use more technical language or like brand names for our supplies. Surgical procedures, we use more of the medical terminology versus what someone would search for on the street. So I would recommend working with maybe your coding department to come up with some plain language descriptions for these services that are easily searchable for someone who doesn't really know all the technical terms that we do. And then also with this, if you offer the item or service at more than one location in your facility, that has to be listed as well. So you have to clearly denote where the service is happening. And then of course, with the charge master file or the rate file, you also have to list all your payer specific negotiated charges. That's a tongue twister for me. And this, you know, like I said, can be really complicated just depending on how your payer pays. You know, for something simple like a colonoscopy, one payer may pay a fee schedule, another one may pay percent of charge, another one may pay like a surgical grouping. So it just all depends on your contract. So this gets also really complicated on how to build this file to make it understandable for the public. And then we also have to list our discounted cash price if we offer one. If not, again, it's the gross charge. And then the de-identified minimum and maximum charges. And then any primary code or any identifier for the service needs to be listed as well. Okay, next. So one thing that they do allow with this is, instead of creating like a flat file and posting it on your website for the shoppable items and services, we could use a price estimator. And a lot of the new electronic health records are also offering a price estimation tool. And there's a lot of vendors that also offer this out there. They can be very costly and they do take a lot of time to implement. So that's something to think about if you're thinking of going down this road. It might not be ready to comply with 1.1 if you're just starting now. But we do have to ensure that it still includes those 70 items and services that CMS has listed, and then an additional 300 shoppable services. So you have to make sure that patients can find at least, the 250, the 230 plus the 70 to get to 300. We have to make sure that they can, you know, do price estimations for at least 300 services. And the estimator only allows you to not have to do the flat file for the shoppable items and services, but you still have to comply with the whole charge master file with all of your payer contract information in there. So this only gets you halfway through. So for some other things to note, they did not formalize a display format. So there isn't anything that says, there's no data dictionary or anything out there that says the file must look like this. So I can only imagine the variety of information that's going to be out there once 1.1 happens. I think everyone can interpret the formatting differently. I may see one spreadsheet with multiple columns, different spreadsheets for each payer, different spreadsheet for each department. You know, I see everyone going a very varied ways with this, just depending on how they can get the information out of their system. And another thing that was not finalized was having to provide a paper copy. You could only imagine how cumbersome that would be if someone requested a paper copy and you have a 14,000 line item charge master. That would be a lot of postage fees. And then as far as compliance, so CMS does have the authority to monitor compliance with this. Complaints can be made by individuals or entities for non-compliance. And they also can go out and audit hospitals' websites to ensure compliance. And if you're found non-compliant, CMS may request a corrective action plan if what they find constitutes a material violation of the regulation, and they may assess a penalty up to $300 a day. So there could be some potential, large fines with this without compliance. And then the burden down below, you can see some numbers that they estimated when it comes to being able to be compliant with the rule on 1/1 of 2021. So a lot of hours involved with this.
And the only other thing I would add is that email address is something out there for anybody to report anything that they see that might not be compliant. So that's just something that was put in the final rule as well for notification of that. And I'm going to take over from here and talk about the industry reaction. Right after this was published in December, then we had the lawsuit that was filed by the American Hospital Association. And I want to say there were some children's hospitals and a couple other large health systems and other organizations that joined. I want to say there were like 7 different entities, and they basically were challenging, the agency's statutory authority to do what they did. That the standard charge definition, we didn't need a definition of what a standard charge was, that everybody knew what that was, and these other things are not really a standard charge. And, they questioned the penalties. They said it violated the First Amendment, which the final rule actually had CMS anticipated having this challenged because they did basically go on and put some sort of argument together in the final rule as to why they did not feel that it did violate any of the First Amendment. And, with a lot of lawsuits, you see that the infamous arbitrary and capricious argument was part of the suit. So this was the American Hospital Association's reaction. This had a tone of, we aren't saying that hospitals aren't saying that they do not want to be transparent with pricing, but that they were ready to help and work towards getting to a place that everybody would be comfortable with. And basically, AHA's argument is that this doesn't really provide the patients any information about costs, and it's just going to, we talk about the brain surgeon analogy. This just is providing a lot more confusion, because if you didn't understand what was posted with just the standard charge master, now we're putting all these rates out there and everything else. And in the end, the patients are really looking for, what's it going to cost me? And, that's not help. The current situation isn't helping that either, when there's, a gross charge. And as Rochelle mentioned, the lingo that we use, it's like CPT code language a lot of times, and it's billing rule language that we understand in the industry, but from a layperson's perspective, they don't. So they just said it basically is not helping the patients, and they're ready to work with CMS and other stakeholders, to come up with a real helpful solution. And HHS's reaction to that lawsuit wasn't as kind or gentler, was pretty much shaming the industry for not, and accusing them of not willing to provide American patients the cost of a service before they purchase it. That the president and the secretary are committed to providing this information. So they weren't too thrilled with the lawsuit. So, November 15th, the final rule came out. December, there was a lawsuit. And I know this was the hottest topic out there until the middle of March. And once the pandemic hit, and even today, now we're scrambling, there were a lot more things that we were focusing on in our industry with the hospitals to keep up with, the pandemic, what kinds of things were changing with telehealth. And, we had the waivers, and I mean, we had a group of people that met, I think it was every day for a good month for a half hour, because stuff was coming out that fast to keep up on all of the things, waivers, telehealth. Can I bill for this? Rural health clinics, how are we supposed to bill for that? Have they come up, and then the PT industry as well had a lot of confusion on, can I provide services through telehealth and whatnot. We had all sorts of different relief funds. We had money that just sort of magically appeared in our accounts based on some prior year Medicare formula that was out there, ensuring that we got the fund money that we were supposed to get through this. And then there's, the payment protection program and everything else. And we were dealing with that, and still are, quite frankly, for, how many months after the middle of March. And I just bring up a couple things here, because sometimes when we would talk about price transparency, and when you would talk to the policy people, the things in DC that were really hot topics before the pandemic, one was surprise billing, and the other was price transparency. And if you would talk to the policy people, their sure bet was on that surprise billing was going to be the thing that was going to happen and get taken care of. And then we got this price transparency stuff. And so that was a kind of a surprise. And I wanted to bring up a couple things that are kind of related to what's gone on with COVID and the relief funds and things under the CARES Act that you should be aware of, because it could impact you down the road. So if you received any relief fund money, there were terms and conditions that you signed off on as receiving part of that, those funds. And one of the things that was in there was that the care for a presumptive or actual case of COVID-19, that you, the hospital, certifies that you're not going to seek to collect from the patient out-of-pocket expenses greater than what they would have been required to pay had it been done within their network. So what this is, surprise billing is actually when they're talking about out-of-network, because if you get treatment out of your health insurance network, it costs you more out of pocket than had you gotten that care within network. And with the way the environment is today, especially now when we're seeing surges in cases, we don't have control over who we're going to get our care from in some cases, especially if you have COVID and it's progressing, and the nearest larger facility that's going to help you is full, and they have to airlift you to a hospital that's 4 hours away. Well, that hospital may not be within your network. So somehow you just need to be aware of the fact that you cannot go after the patient for that additional. They shouldn't be billed as if they were out of network. It just would be whatever they were, so kind of look at the denials and things, and some of those reason codes that come across. This one to me is kind of a harder one to get your arms around, and we've talked about it amongst our group too, to see how can I best prepare myself so that I don't have, I'm not going after somebody because they had more out of pocket. So that's what surprise billing is. And the other one is if you did submit claims through the uninsured, that claims portal, you cannot balance bill the patient for the difference between what your charge was and that payment you got, which I think was equivalent of the Medicare payment. It was a matter of you getting zero payment or a Medicare payment on those claims. So if you had $100 charge and you got $30, you can't go back to the patient to bill that $70 difference. So just a couple things sort of related to pandemic and transparency, and just to keep you aware of that. So, we're worrying about, COVID. It's from the middle of March, and then on June 23rd, that lawsuit was found in favor of HHS. And I know I actually was at a hospital on a project, and that's when we learned about it, and everyone was scurrying and couldn't believe that this really, with the pandemic, that now I'm going to have to worry about price transparency for 1/1 of 2021. And here we are today in November, and yes, we still have to worry about it. So obviously they the plaintiffs filed an appeal the next day. AHA sent some letters urging, HHS and CMS to delay this. Back in July, there was a brief filed, and oral arguments were heard on October 15th. And just from what I've read about that, the judges were not sympathizing with the hospital industry, their argument. They couldn't quite get there. So it didn't sound really good. I'm not giving a legal opinion on anything, but just from reading their responses, they just weren't sold on the argument that this isn't going to help patients understand more about how much stuff is going to cost them. So one thing that has happened is within the last month or so, CMS now has a web page. So look at how many months passed between, because they were busy too dealing with all the waivers and everything else. But we finally have a web page for price transparency, and I've provided the link there, and there's a section that's for hospitals, and then there's one for consumers to go to. Might be something that you want to take a look at. Maybe it's something you want to link on your own website so patients can go to that if they have additional questions. But on there, I would encourage you to at least look at, there's a compliance checklist. It might be something that you can go through and say, okay, we've done this, that, and these things. What else? Where's the gap? Where are we at with our, implementation? Frequently asked questions section. We really didn't have anything until this point. Back when the January 1st, 2019 came out, the final rule comes out, in November, beginning of November, and we had to get this implemented by January 1st. Well, at least there were some frequently asked questions. But again, because of the pandemic, CMS was really busy working with all the hospitals and having these office hour meetings to answer those questions. But now we have that. And then they talk about something more about the machine readable file, and goes into more information around shoppable services. So highly encourage you to take a look at that if you haven't already. I bring this up too because, this is all, we're worrying about the federal requirements, but you still might have state transparency rules and requirements. It's really important that you don't lose sight of those, and that you still, know what they are, and that you've got a process in place, and maybe bring it into your federal rule implementation as well. So what's next? I mean, if you thought before with the current state we're in, where we're posting our just gross charge from our charge master was mind-boggling to people, this is more mind-boggling. I bring up these other considerations though, because these are all things that I've heard people talk about, and I've been to different conferences and they've brought these things up. And one of this slide in particular was something that I heard at back at a HFMA conference, and the national HFMA person was there and spoke directly to this thing, this slide. Basically, you know, they're still talking about the tax exempt status being called into question. So nonprofit hospitals, and those of you who've been in the industry for a while know this has not gone away. It kind of keeps rearing its ugly head. But one of the things that hospitals have been called before the Senate Finance Committee, and you know, some of the things they're asking them are not only about, you know, their collection practices, but also how do you set your charges, and what's your pricing policy or strategy. And I know in working with hospitals, a lot of times we'll ask, do you have a price strategy? Do you have a philosophy? Do you have a policy? And a lot of times they have something and they can speak to it, but it's not anything formal or written down. So I'll speak a little bit more about this in a few minutes, but I highly encourage you to talk about what that is, what your process is, and have it documented. And you can incorporate this price transparency implementation as part of that. The other thing that you know has been talked about out there is this something that's going to end up not just being for hospitals. We already know that for hospitals that employ physicians and do the billing for them, and or other, you know, healthcare billable type providers, they are supposed to be, we have to include those charges. So what's to say that professional independent practices may not be part of this, or other types of providers besides hospitals? I think it was the day, it was close to when the final rule maybe came out with price transparency. There's this transparency and coverage proposed rule. This was talking more about, you know, surprise billing was in that. So something to keep a pulse on, what sorts of things they had in that. Some of the things that were spoken in that kind of did end up in somewhat what the price transparency final rule was, when they talked, you know, they asked about negotiated rates and things like that. Will quality be tied to standard charges? I don't know what that would look like, but that's something that people have sort of talked about. And then value-based care. And then the stuff that's highlighted here, this was something that, again, as I mentioned, you know, CMS was looking for comments about the continued value of charge master charges and setting hospital payments on the prospective payment side of things. Well, I think that this 2021 IPPS final rule, the changes that I mentioned earlier in the presentation around managed care, you know, the Medicaid or Medicare Advantage plan, having to post those rates as part of our cost report going forward as a prospective paid hospital, not a critical access hospital. But I think that's where that came from. And I only bring some of these things up because sometimes you wonder, where did this stuff come from? These are things that, you know, like that item that Rochelle spoke about earlier about providing a paper copy of some big document of stuff. I mean, it was put out there, and sometimes you have to go back some iterations to find where did that come from. So, work plan towards your 1/1/2021. Despite the lawsuits, this is full steam ahead, and I'm sure most of you are in the midst of getting that if you haven't already, gotten at least components of it. I want to just mention again, there's two requirements. There's the machine readable file, and then so that's no matter what you do with shoppable services. The other piece is I have to report on, as Rochelle said, the flat file on my website of the 300 items and shoppable services, or I can do that through a price estimator. There's been a lot. I've gotten calls from hospital CFOs saying, so I've got the price estimator, I'm good, right? Well, do you have a machine readable file? Well, no, there's been confusion there. So I just wanted to make sure we clarified that. So then it's a matter of, implementation, timeline, milestones, who's doing what, a project plan. And I know this sounds kind of formal, but I feel like either you incorporate it into some sort of a ongoing meeting that you already have at the facility. If you have some sort of a monthly or weekly rev cycle meeting or business office group, we're coming up with the CPT code changes, all that kind of stuff kind of fits together. And why not incorporate this into that type of a forum? Who's executive sponsor? Is that the CFO? And I know, again, critical access hospitals, a lot of times, we wear multiple hats. We don't need to be so formal, but I just feel like it should be something that should be documented and a little bit more planned out. Who's going to manage this project, and who makes up the work group around it? So, this slide actually was from the presentation I did in February before COVID. This is what we would have wanted to have, right? You wanted to have a fair amount of time to get ready for this January 1st implementation. And here it is, even the last quarter of the year, a lot of people are still scrambling to get the thing where it needs to be. So I still think these are important things for you to consider. This isn't not like as Rochelle said, one and done. This is an evolving, living thing, and you have to view it as such. I don't see it going away. Maybe it gets tweaked, but once it's out there, I just don't know how they would retract on it. So again, my opinion, not Eide-Bailly's, but one thing to consider, Chargemaster review. So hard thing is, if we got a lot of lines and a lot of stuff that we don't really use, why would we even want to put that on the website? Might we have an opportunity to bundle some things? So if you haven't had a Chargemaster review in the last 3 to 4 years, it might be something for you to put out there on your work plan as something to consider doing. Do we understand if our prices make sense? Where do we sit within our market pricing? Have we done some sort of peer market analysis? One thing that this exercise is of benefit for you is that with all those negotiated rates, it's kind of forced you to put all that on in one kind of a place. And for those who have worked at pricing and been kind of more involved in that, that's one component that I'll talk about in a bit, but that is one of the things you want to look at is multiple things impact how I set my charge. So if you haven't had like a peer market comparison or gotten market comparative data, or you've just kind of had a process of where I go on other people's websites now that they post their Chargemaster to look at specific things. And sometimes that's what we do to, you know, just as we got a new thing that we need to add to our charge master, we kind of use that methodology. But that's something to consider having done a more formal analysis that way, which would also support your pricing from a defensible perspective. You know, we already go through the contracts. That's one thing you've probably done already. You know, do we know who we have our contracts with? Some places, just due to turnover and whatnot. You're new coming into the organization. It's like, I don't even know where our contracts are. I don't understand. I don't know, you know, where they kept them, who we have arrangements with. So another thing to add to the work plan. You know, are we doing a price estimator or not? And then our pricing policy and how we set our charges. And, you know, what's the source of truth for the 5 different types of charges? I mean, the de-identified minimum and max is purely a you know, that's obvious what that would be. But the other 3 things, what are those? What's the source of truth, especially for those negotiated rates? So why does pricing matter still? You know, I spoke about Congress still looks at this, you know, for tax exempt status. This is, you know, I say we should be able to explain our charge and how it was arrived at the charge code level. You know, patients might not, you get a question, they're complaining about their bill, and then you can go back and check off, yep, all those things, that is our charge. And we were, you know, this item was based on market, or this item was based on patient complaints. This item was based on a cost plus a markup. And that's the defense of it. Now I say, they may not like the answer, but at least you know how the charge was arrived at. So when I talk with people about pricing, I say, and even when we do market analysis, it's a math calculation. It's a lot of data. We, you know, we calculate a formula and then we look at it and compare it to the market. And that's where the art part of it is. So it's like a lot of science, but then there's the art. It's just, there's a lot of factors that go into it. It's not like you do this market comparative analysis and voila, that's your number. That's the start. It takes a while to get to that point, but that's really the start of it. And then you go through and you look at, you know, is this something that we do based on cost plus a markup, like in the supplies area as an example, or pharmacy with their formularies? And the other thing is, well, we want to be at what percentile of the marketplace? Is it 50th percentile? Is it the 75th percentile? That's something too. Once you've made that decision, that's where would be part of your policy. And you can make a decision to not do something like that, but you would know why you varied from your standard policy. The other thing is if you have contracts where you've negotiated rates, and one of the things in the contract says it's the lesser, you will get paid the lesser of your charge or the negotiated rate, and you're getting paid your charge, that means that you don't have your charge high enough. You always want to make sure that you have that charge above that highest paying payer rate. So sometimes that's what we set that rate at. You know, but you're looking at all these different factors. So what I would say is define what you do in a policy, include any unique markups, you know, from supplies, pharmacy, lab sometimes has different pricing models. What's your general policy, and note those areas of exception. This would be something too, when you do annual price changes, who's responsible for that? Interim price changes, what's the process around that? How do we look at for something new that we don't have? And how do we set that price? Charge strategy, you know, I would highly engage the clinical departments. A lot of times they know a lot more about the market around their service. And they may say, radiology is one that people shop around for a lot. And maybe there's something, maybe we keep radiology more in line with the the competition, even if it's somewhat on a freestanding basis. Where else then can we, maybe increase the pricing? And maybe it's not on everything in radio, it's maybe a couple tests that we know I would rather not have our community patients feel like they have to drive, an hour or two to get something done when our pricing could have been adjusted to accommodate some of that. Patient complaints obviously is another area that maybe helps with some of the strategy around charging. If your cost to charge ratios look to be like 1.0 and above, there might be a reason for that but it could also point to maybe something with your charging not being where it needs to be. If you get, again, I spoke to this, if you see that you're getting paid 100% of your billed charge, then there's maybe something not right about that charge, the way it's set. Sometimes too, I think we feel like if we charge for these things and we're percentage of charge based paid from a commercial plan, that we feel, well, we're going to get paid for it. Sometimes you'll realize that if I bundled it, I would have got paid for it, but because I chose not to bundle it in the health plan, then you get the claim back and it's denied, it didn't pay on that item. Well, because they thought it should be bundled, well, then you're not getting paid for that in essence. So those are some of the things to look for. I know that a lot of states and even your commercial contracts on percentage of charge, you're limited to sometimes, you can only go like 3% or 5% overall increase from year to year. That's overall. So that's something to keep in mind. And a lot of the payers have time requirements for that they need to be notified of these increases. So you have to be aware of that. Align with the budget process and your contract negotiations for those very reasons. And keep your CDM person and coding very in tune with finance, especially around budget time when the CPT codes change. And I will use this example. If you have a change in how we can charge for a procedure or a test, and it started off where we used to charge this for 3 different charges, and now they will only let us do it in 1 charge. If finance doesn't know about how that's working, we may fix it in the charge master. We need to make sure that the charge we set for that is correct. So working with finance on that. If we don't have that conversation, as we go through the year, we're going to wonder, why are our charges so off in this area? And speaking from personal experience, if you don't talk with the people who set it up in the price file, the charge master, they've set it up right, and maybe they weren't in tune with how to set the charge itself, you can have issues with having budget variances, and you want to make sure that things are budget neutral as you change them. So with that, I'm going to turn it over to Rochelle to talk about technical considerations.
Fun stuff. Yeah, so I'm just going to go through some more technical detail. I'm assuming everyone's kind of preparing right now. If you're not, you should be, to get the file ready to publish for 1/1. So these are some things that I've kind of run across, some questions I've had, and other information that I've gleaned from the FAQ that's now out on the CMS Price Transparency website. The FAQ is actually very helpful. It answers all the questions that I had or things that have come up that aren't clearly defined in the rules. So I recommend going out and referencing that when you have a chance. But some things to consider when you're going through the file development, what if we don't have a cash rate for an item or service? Like I touched on before, you would post the gross charge amount. So just your standard charge amount that's in your charge master for that. Um, what if there's no CPT or HCPC code for an item or service? You would still need to list it in the file. Just because there's no billing code doesn't mean that it shouldn't be published. If you do get separate reimbursement from any payers in which you have a contract, that item or service still has to be listed without a CPT or HCPC code. You could choose to use some kind of other indicator if you want, but it's not required. And then how many payers do I need to list? Is there a limitation? The answer to that is no. You have to list all of your payer specific standard charges for all item and services in which you receive reimbursement. So like I said earlier, you may have a payer that you have a contract with, but then there may be subcontracts under that with the different plans. You would have to list out each one of those individually in this file. So the file could be massive very quickly. You may have 15 pairs that you contract with, but you could have a couple contracts under each one of those. So just multiply that out. And if you're doing the file on one page with multiple columns, that spreadsheet's going to get awfully wide. So make sure you have a really widescreen monitor when you're doing this. It makes it a lot easier. So, you can see the quote I have there from the rule. For many hospitals, particularly large hospitals, this may involve display of data for potentially many dozens of payers and plan products, which is definitely true. Next slide. And this is just an example, a very simplistic example of file format. So you can see your department, your charge code, your CDM description, any CPT, HCPC codes, revenue codes, your gross charge as your facility, your self-pay rate, and then those are very simplified made up numbers for contract rates. One thing I would recommend adding to this as well, differentiation between inpatient and outpatient. Some services may only be paid on an outpatient basis. Some may only be paid on an inpatient basis. And that's something you're going to want to differentiate in that as well. So maybe adding, under, let's say, Blue Cross Blue Shield, you add 2 columns, one for inpatient and one for outpatient. So again, the file becomes even wider. So next slide. So with the shoppable services, not all your payer specific negotiated charges are found in the hospital charge master. Like I was saying, it depends on how your payer pays for them. So there's a lot of complexity around pulling this information and compiling this information. Like I said, it all depends on if you have your item set up in more of a bundled manner, like Amy talked about before, when you do a charge master review and see that your line item listing out everything, it may behoove you to roll them up into one standard charge in your charge master. It's easier to maintain in the long run, and it's a lot less complex as far as getting estimates to your patients, because all of that comes into play. Even if you do an online patient estimation tool, it's only as good as the data you feed it. So if you're not taking all of that into consideration, your patients may be getting kind of out of whack estimates for what they're going to pay. So like I said before, you might have to pull information from other systems. A good resource is the 835 file. It has all your payment information from your payers in there. Once you get paid, one thing to look at with that is your payers might not be paying you your negotiated rates. So this is another time to spot check that as well. Since we're getting into these details, it would be a good time, if you don't have a more complex contract management system, to use this data to your advantage to see like, okay, I'm supposed to be getting paid this rate from this payer. Comparing it to your claims data, are we actually getting this rate too? And going back to your payers if you're not. So I see this as just a massive cleanup effort across all aspects of the rev cycle and like finance, accounting, and everything to get all of our ducks in a row in the system. Again, too, the shoppable services require a plain language description, so we can't always use the description that we have in the charge master file. They did in the rule suggested using the federal plain language guidelines. I did go out to that website and I didn't find it super helpful, but they do have plain language guidelines out there to use. I would, maybe have a work group within your facility that isn't tied into the technical aspect of things and would give recommendations. If I was looking for this service, here's the keywords that I might use. And you might want to have, more than one column for a description in the file as well, depending on how people might search for what they're looking for. Some of the price estimation tools have that. You could type in different words for the same thing and come up with that estimate. So next slide. So this is an example of the shoppable service file that was in the Federal Register. This is, kind of how they said or thought that the file might look if you did the flat file versus the price estimation tool. And again, you can see some of the complexity in this. Like I said before, the colonoscopy, some of the payers may pay for it just at a flat CPT code level, like we're only paying you for the primary procedure and we're not going to pay you for any ancillary fees that you have with that. Some may pay you for every ancillary item and service that you bill in conjunction with the primary procedure. So like I said, this file could get very complex, even though it seems like it's pretty straightforward. There's just a lot of things to consider when you're building all of this out. So next slide. And then the price estimation tool. This, as we've said a few times now, but just because there is so much confusion around this, this only replaces the flat file for the 300 shoppable services. It does not replace the big master file with all your individually priced items and services in which you have a contract payment rate for. So this is only half of it. And again, the price estimation tools, they can be very costly and they can take a lot of time to implement. So if this is the route you're going to go and you haven't started already, I would recommend getting on it right away. And again, making sure that the information you're providing is actually correct. So do a lot of auditing with this, making sure that, if patients can put in the type of insurance that they have, that it's actually giving them the correct information when it spits it out. There's a lot of nuance to these tools that I feel like some places miss when they implement them. And then again, it must include those 70 items that CMS specifically states. And then again, up to 300 in total for the price estimation tool. So that's still part of it. You can have more than that, and most likely you will have more than that, but we must include at least the 300 with the 700 CMS specified, not 700, 70 CMS specified shoppable services. 700 would be quite a bit. I'll pass it back to Amy.
So just some things to consider, do you have a formal charging or pricing policy? And if so, do you feel that you have defensible pricing? And are you set up for success for 1/1/2021? This is at the end of the presentation. However, I just want to say a few things in closing. One, hopefully you've understood the transparency requirements, that we just spoke a lot about the federal rule requirements, but don't forget about your state transparency rules as well, and incorporate that into however you're doing your work plan or project plan around this. You still should assess the readiness of the key attributes, all of those things, the 5 different standard charge elements now, the negotiated rates. Do we understand where we're getting that information from? Are we using, have we chosen to use 835 data to help us with that process? What's the plan and what is this governance structure? Again, sounds real formal, but sometimes some of these things, this is like we've said a few different times, this is not a one and done, and it's going to be an evolving thing. This is something that's going to have to be done and managed, as you have major changes to pricing. Even though you're only supposed to do it once a year, maybe it's more efficient to actually do it when, we had a price increase. Do we need to do that and update that? And clearly denoting the date of when that happened. At least you would be in compliance with the annual update. Demonstrate active efforts towards your compliance. And what I mean by this is, I know everyone's like, I think Rochelle just mentioned this, is there a minimum requirement of how many negotiated rate things or health plans or contracts I need to report? Should I just do the top 5? You know, we're gonna scale it back, then have as part of your plan how you're gonna get to where you need to be. So as long, I feel that, and I get, I'm not gonna be the auditor here coming in if that's what they'd end up doing, but I feel if you are making an effort and you have a documented process and you're showing progress and you've done something to comply on 1/1 and you've got a plan to get where you need to be relatively within a reasonable time in that first year, I feel that goes a long way. But if you feel like, I'm just going to throw my hands up and not do anything, that's not going to go over well. So make a good faith effort. That's what I would suggest. And I feel like everybody's trying to do the right thing. And if it is that we have the price estimator, and that's where you've spent a lot of your effort, what's your plan to get the other piece of it in place? Again, assume the implementation date is firm despite all the litigation that's out there around this issue. Even without, we've already started the process as of 2019 where we posted our standard charges. Look at what you're doing currently too. If you have a PDF file now, we know that's not going to comply. So how do we get where we need to be, at least to get up to speed with what they're asking and requiring of us for the 2021? The price policy, defensible pricing, what does that mean for your organization? How do we get there? What's our charge strategy? And all those things are important. And maybe that requires a couple conversations at the organization just to get that started and to put it in a formal policy. And this is going to be a lot of data. We who work in this industry know the complexity of this, all of the information. We've had the conversations with people, friends, family. They get their hospital bill and it's shocking to them how much it costs to do this when it's really the gross charge, and having to educate. So what I say when I'm saying this is a lot of organizations, even with the 2019 implementation, did a really nice job trying to explain what this data means, help them understand how to utilize it. What are the, especially some of the stuff where, where you're a provider-based clinic, what does that mean? Why is it that you're going to see higher charges coming, and that they should, when they're comparing, they need to understand those nuances. The more that you can provide, education, and maybe you have, and you just enhance that, that can go a long way. Back in the day, I want to say a couple years back, the Healthcare Financial Management Association had a really nice brochure that I thought they spent a lot of time working to help educate patients, and was something that organizations could, if they wanted to, have it laying out for patients to pick up, or and I don't even know if they still have it anymore, but it did a really nice job on explaining, well, what is cost? Well, cost depends on what it means, who's the person asking and in what context, right? What do we mean by charge? So that's all stuff that I feel, might be something that if you could find something like that to help guide you in helping explain some of this stuff on the website, I think it goes a long way. So with that, I'm gonna see if there's any questions for Rochelle or myself.
There's one here that says, do we have a rev code?
And Amy, I can take that if you
Okay.
want. I'm assuming that to be, do we have to report the revenue code? I'm not 100. Okay, yes. So I have the FAQ right up in front of me, and they define the comprehensive machine readable file and the consumer friendly display side by side. And what they say in this is, description of item, service, and billing codes. And it states a description of each item or service along with, as applicable, any code used by the hospital for purposes of accounting or billing the item or service. So I would interpret that to mean, yes, if there is a revenue code associated with an item, you should be putting it in the file. So I hope that answers your question. Oh, yes. So the question is, I mentioned needing to list each additional plan, and this must have been a larger system, but they said if they mentioned every individual plan that it would require over 1,200 specific lines. I would say if the plans have the same payment type or payment, if they're all fee schedule and it's the same fee schedule, or it's percentage charge and they're all the same percentage charge, then you wouldn't have to get to that specific level. But if there is variance in the payment rates in the different plans, then I would say, yes, you should be listing those out. And that's where I'm saying, like, this file could become massive very quickly. So some recommendations I've seen, okay, good. Some recommendations that I've seen is potentially having a different tab for each of your payer plans. If you do have something more complex like that, let's say, I've used this example many times, but Blue Cross Blue Shield, if you do have maybe 5 different contracts under that and each one does pay differently, maybe you want to put them on a different tab so that spreadsheet doesn't get extremely wide to the point where it's not really viewable and it's not that easy to use for somebody searching.
I do want to make one comment that I forgot. We didn't say, as we talk about these getting, and I see Brittany has a question out to people participating in the call too, if are you having luck getting fee schedules from the health plans. One thing to make note of, we do know of some health plans that have outright sent letters saying you are prohibited by your contract with us to publish the negotiated rates. And so that poses a dilemma, right, for the hospitals. And so I would look at your contracts, and if you have that prohibitive language, I think we've heard some recommendations that you should really go back to the health plan to ensure that there's not going to be an issue with you reporting that information. You may want to seek out some legal opinion regarding that. If they, and it would almost be to the point where if you're going to publish this and they give you okay to publish it, looking at removing that language from the contract. But that has come up, and we are aware of some of a health plan that has currently put out their position, and that's what they said, you cannot publish this. That being said, without getting any sort of legal opinion, I guess you'd have to disclose that for that particular plan. I can't think of any other thing to do at this point other than work with the health plan, look at the language. Is there something from a legal perspective? Usually it impacts a lot of hospitals within the same state or region. Maybe have to involve some larger hospital groups potentially to have conversations there.
Yep, exactly.
All right. Well, Amy or Rochelle, if you have any final thoughts there.
No, I thank everybody for signing up and participating in the webinar today.
Yes, thank you all.
Well, thank you all so much for attending, and thank you to our presenters, and we hope everyone has a great weekend.